Thank you very much. Ladies and gentlemen, let's move on to the next topic at hand. That is a symposium on acute coronary syndromes. May I invite the panelists onto the stage, please. Senior Consultant Cardiologist, Dr. W. Shantaraj, Senior Consultant Cardiologist, Dr. Stanley Amarasekara, and Senior Consultant Cardiologist, Dr. Nimali Fernando, please.
Good evening, Professor Mario Ajli. Welcome to the next session, that is ischemia with myocardial syndromes. Let me introduce you. MBBS MD, Chairman, Cardiovascular Medicine Division, University of Pisa, Director, Postgraduate School of Cardiology, University of Pisa, Visiting Professor of Cardiovascular Research at the Henry Ford Hospital, Editor-in-Chief of Heart and Metabolism, Editor-in-Chief of Clinical Cardiovascular Drugs, Fellow of the European Society of Cardiology. Professor Mario, you will be having a large virtual delegates number registered with us, and we have our council members because of the COVID-19 situation, and there will be a lot of spectators, and we are honored to have you here for this presentation. I invite you to start with.
Thank you. I think it's extremely important to focus on this nomenclature shift from disease to syndrome for myocardial ischemic condition. So I will try to quickly try to understand why the European Society of Cardiology proposed this nomenclature shift and which kind of changes we have to expect in the future in our daily practice. Let's first check on Wikipedia what is the main difference between the words disease and syndrome. Well, according to Wikipedia, a syndrome is a set of medical signs and symptoms which are correlated with each other and associated with particular disease or disorder. But when a syndrome is paired with a definite cause, this becomes a disease. So according at least to Wikipedia, a disease has a specific, well-identified and unique cause. The syndrome is a condition where there may be multiple mechanisms. Now, this is a cultural shift even before a nomenclature shift, because the 2007 edition of the European guidelines were, I would say, quite restrictive on this topic, because the statement was that the most common cause of myocardial ischemia is atherosclerotic coronary artery disease, and other conditions are so rare that they do not deserve to be considered in the guidelines. So in 2007, myocardial ischemia was a disease, but this concept did not hold a closer scrutiny. And this model that was reproposed more recently on the New England, that a coronary atherosclerotic lesion is the common background of myocardial ischemia, does not hold the challenge of scientific evidence. I am fully aware that this conception is very popular among cardiologists, but it simply does not fit with the scientific evidence, as I will try to show you in a moment. This model is extremely simple, and that's one of the reasons why it has been found so attractive for decades. Because according to this model, myocardial ischemia is consistently associated with the coronary atherosclerotic plaque. the plaque may grow slowly in time, and this is supposed to be the background of so-called stable angina, while the plaque can increase abruptly, and this is supposed to be the background of the acute coronary syndrome. Of course, in my lecture, I will focus only on chronic ischemic syndromes. But this link between myocardial ischemia and coronary atherosclerotic lesions is not supported by a convincing evidence. Several years ago, we summarized the evidence challenging this conception and suggested that the link between ischemic heart disease and coronary atherosclerosis is much more elusive than we commonly think, and in a sense that than we would like to be. And the reason why this link is so elusive is because there are a number of other mechanisms that can independently or in association precipitate myocardial ischemia. And we listed, in addition to the coronary stenosis, inflammation, platelet and coagulation disorders, vasospasm, microvascular dysfunction, and endothelial dysfunction. Most of these suggestions were received and accepted by the 2013 update of the European guidelines. And in 2013, there was a table on the guidelines where were listed different and multiple mechanisms as responsible for myocardial ischemia. If you focus on the lower part of this cartoon, you will see that the mechanisms responsible for myocardial ischemia may include fixed or dynamic stenosis, microvascular dysfunction, focal or diffuse epicardial coronary spasm. But in my perception, the most important warning of this table is in the last line, where they wrote, the above mechanisms may overlap in the same patient and change over time. This is extremely important for our daily practice because it warns the cardiologist that even if a patient has a fixed stenosis, he may also have microvascular dysfunction or coronary vasospasm or other abnormalities. And this provides an explanation for the so common observation of patients in whom the stenosis is removed and ischemia persists. And there is another additional warning in this last sentence, that the mechanism responsible for ischemia may change over time in the same patient. So ischemia, myocardial ischemia, is perceived here as not only as a multifactorial condition, but also as a very dynamic condition. And then we come to the latest update of the European guidelines with this nomenclature shift from disease to syndrome. So to a condition that may be associated with multiple precipitating mechanisms. But the guidelines, the latest guidelines, also offer a very, I would say, striking information of how relevant are those alternative or additional, or let's say not atherosclerotic, non-atherosclerotic mechanisms in angina patients. Because if you focus on this table, that is table 5 in the 2020 publication of these guidelines, and you look at the prevalence of coronary stenosis in patients with typical angina, that in the past were supposed to all of them have a coronary stenosis. Now you see that, for instance, in the age range between 50 and 59, only 32% of male patients do have a coronary stenosis, and only 13% of the female patients with typical angina do have a coronary stenosis. So the message here is quite, I would say, surprising or deeply innovative, because these guidelines are telling us very clearly that the vast majority of patients suffering with typical angina pectoris do not have a coronary atherosclerotic stenosis. So why are they ischemic? Well, these are some of additional mechanisms that are also, in part, I quoted in the past, in very recent publication, that should be considered in patients presenting with typical angina. It include, in addition or even in the absence or in combination with an occlusive coronary artery disease, coronary macrocirculation that may have structural abnormalities or functional abnormalities, and myocardial factors. And as clearly indicated by CathPCI in this editorial, there may be even non-vascular mechanisms precipitating myocardial ischemia that may be at the cellular level or transcellular level or intracellular level. So you see how the scenario of myocardial ischemia becomes complex and complicated. So where do we go from here? What does this shift from disease to syndrome implies for daily practice? This is something we have to explore, we as cardiologists have to explore. In my perception, one of the main implications is that when we have to deal with the patient with typical angina, when we have to manage an ischemic syndrome, we have to start considering that the diagnosis of angina and or ischemia is distinct from the identification of the precipitating mechanism. So far, just seeing a stenosis was the equivalent of diagnosing myocardial ischemia, and seeing a clean coronary was almost an immediate exclusion of myocardial ischemia. Well, this approach is no longer tenable. The diagnosis of myocardial ischemia must be directly based on the manifestations of myocardial ischemia that are symptoms, as you know, EKG changes, regional wall function abnormalities, myocardial perfusion defects, and for the more sophisticated of us, lactate production. These are the elements that are required to conclude this is an ischemic patient. Because as the guidelines have told us, 70% of patients with myocardial ischemia have clean coronary arteries. Then there is another step that, okay, this patient does present with symptoms and or signs of myocardial ischemia. The next step is, why is he ischemic? Which and is or are the precipitating mechanisms of myocardial ischemia? This is a new area to be defined, to be explored, and to be, let's say, characterized better. But certainly, we do have clues from very simple tools. Medical history is extremely important. If the patient tells us that he can have angina, typical angina, any time of the day, with no apparent precipitating mechanism, no exercise, no emotion, no cold exposure, he's suggesting us that quite likely that ischemia is precipitated by a functional mechanism. If that patient tells us that every time he climbs 3 flights of stairs, he has to stop because of typical chest pain, he's suggesting us that quite likely he has a fixed obstruction in one of the largest coronary vessels. And then we have to start using the stress testing in a more, let's say, tailored fashion. If a patient reports angina at rest, he may well have a negative exercise test. But this negative exercise test does not rule out myocardial ischemia in a patient reporting resting angina, and vice versa. So when we have a patient that complains with typical angina, we have to consider, as we suggested in this review on Nature Review in Cardiology, that it could be a functional mechanism, could be a microvascular angina, could be a classic post-stenotic angina. And this option should all them be considered and not be too simplistic. Say, the stress test is negative, you have nothing. This is very misleading. Remember, 90% of the female patient with typical angina and with all the prognostic implication of typical angina and myocardial ischemia do not have a coronary obstruction. So in this new scenario of chronic ischemic syndrome as a complex multifactorial condition, we must use the tools that we have, including medical therapy and revascularization procedure, no longer as alternative, but as resources to be used according to the individual patient needs. The 2019 European guidelines are not very optimistic about our current management of chronic ischemic syndromes, chronic myocardial ischemic syndromes. Because in the guidelines, there are, let's say, not very encouraging statements, because they say optimal therapy for angina does not exist. No drugs that reduce symptoms improve outcomes. No data support that one class of drugs is superior to another. This is what the evidence says. So we must be a little bit possibly more humble in our approach to this condition. And simply adding one agent to another not necessarily brings to the optimal therapy. And actually, a number of trials in the past have concluded that the combination on 1 or 2 or 3 hemodynamic agent, and by hemodynamic agent, I mean agent that interfere with heart rate or blood pressure, etc. I mean, the combination of 1 or 2 or 3 does not provide better results. So we have to face reality. None of the classic hemodynamic agents has been shown to prevent myocardial infarction or cardiovascular death. In other words, none of these agents has been shown to impact on prognosis in the patient. All of them are focusing on coronary blood flow or myocardial oxygen consumption, because they were designed based on the assumption that if you have ischemia, you must have a flow-limiting stenosis. But this is no longer the current culture in cardiology. And if not all, as was stated here by Dr. Abrams, but certainly many of them have relevant limitation because of side effects, unpleasant side effects, and contraindication. So from now on, if we accept the message of the society that myocardial ischemia is a multifactorial condition, we should start in trying to tailor the drug choice to the mechanism precipitating ischemia in that individual patient at that time of his natural history. And given that this treatment has basically not a fixed duration in time, the concept of efficacy and tolerability must be considered together with the availability. And then we have to start considering that we not treat angina, but we treat a patient with angina. And most of these patients do have relevant comorbidities. You are all well aware that 70% of the angina patients are hypertensive, from 20 to 30% are diabetics. Many of them have heart failure, stroke, peripheral arterial disease. So the drug should be selected considering these relevant comorbidities. And if we do all of that, can we assume that we are doing enough? I don't think so. I think we can do even more or even better if we focus on the essence of myocardial ischemia. If we shift, even in this perception, from the flow to the energy metabolism, and we are fully aware of how complicated and complex is energy metabolism, we can have some clue. You know, dear colleagues, the heart is a fantastic pump that pushes almost 10 tons of blood per day. 10 tons of blood is an incredible amount of work. And it performs this work transforming chemical energy in mechanical energy, more or less like an engine in a car that also transforms the chemical energy of the gasoline or the diesel into mechanical work, bringing you from home to the hospital. The heart is really an organ that burns a lot of energy. The peculiarity of the heart is that this energy does not come from outside. It's not like in your car that you stop at the gas station and fill the tank. The heart needs to produce the energy it has to use to perform its work. So it's a very unique situation. And the amount of energy is extremely elevated. The heart needs every day from 6 to 35 kilograms of ATP. ATP is the fuel of the heart. And every day, a single heart burns from 6 to 35 kilograms. This is the kind of work that the cardiac cells have to perform, and this is the amount of energy they consume every day. It's an incredible task, and if anything goes wrong, you can have inadequate energy production even if the coronary flow is perfect, because ATP is not delivered by the blood to the cells. ATP is synthesized inside the mitochondria using substrates that are delivered by the blood. So in the blood, there are the substrates, mostly free fatty acids and glucose, that the cardiac cells needs to produce ATP. But of course, the delivery is not enough. After the delivery of these substrates, there are a lot of very complicated steps before reaching the final product that is ATP to the contractile machinery. And if anything goes wrong in this long journey, the cardiac cells may suffer from ischemia, not in the sense of lack of blood, but lack of energy even if perfusion is perfect. Now, I want to conclude my presentation focusing on an agent that can modulate cardiac energy metabolism, in the sense that can stimulate the cells to use mostly glucose instead of free fatty acids. And this is beneficial because to produce ATP from glucose is less expensive in terms of oxygen requirement than producing the same amount of ATP from free fatty acids. Now, this beneficial impact of metabolic modulation is not just an hypothesis. It has been proven in human models of transient myocardial ischemia that we deal with every day. During PCI, we occlude transiently a coronary artery. During bypass operation, we perfuse the heart for some time, not with blood, but with a cardioplegic solution. Both procedures are associated with a certain level of cellular damage that manifests or produces troponin release. Well, in these studies, the release of troponin associated with percutaneous or surgical revascularization is significantly and markedly reduced if the patient does have on board trimetazidine. So this cardioprotective effect of an agent that modulates myocardial oxygen metabolism is not just an hypothesis, but it's been proven in human models. And of course, it does translate in clinical benefit by reducing the number of ischemic attacks and reducing the need for nitrates. Why I am presenting to you this data after the introduction and the emphasis on the shift from disease to syndrome? Because not always is possible to identify the mechanism responsible for ischemia. And that's why an agent that has this impact independently from the precipitating mechanism of ischemia is of great interest. And the efficacy in support of this opinion is that the efficacy has been shown also in patients where the ischemia was attributed to a stenosis, but in whom ischemia persisted after the removal of the stenosis. And in those conditions, that means no stenosis, it's difficult to expect benefit from agent that modulate coronary tone or vasodilating tone. And so I'm
Mario,
going
you
to
have
the conclusion.
almost 1 minute more to.
Okay, thank you. We are living a very difficult times because of the COVID pandemic. But the COVID pandemic offers us also an opportunity to, let's say, to consider this suggestion of the European Society of Cardiology and to apply, because all over the world, the access to revascularization procedure has been dramatically reduced by the pandemic. So we should make an additional effort in managing this patient with a medical therapy. At least in Europe, the reduction is exceeding 50%, and many cath labs have stopped performing elective procedures. So this is an opportunity to focus on this approach that is more consistent with the new conception that I am trying to summarize in my last 2 slides. Chronic ischemic syndromes refers to a complex, dynamic, multifactorial syndrome that is a lifelong condition in which antianginal drugs remain the cornerstone of the therapy. Therapy that should be initiated immediately at the time of diagnosis and maintained for the life of the patient. Once a patient is ischemic, it's like a patient that is a failure patient. He will always be an heart failure patient. And drug therapy should be tailored. We have to make an effort to combine the most appropriate agent with the mechanism that we believe is responsible for ischemia in that patient. And I propose to you an agent that is a metabolic agent that does not interfere with heart rate, blood pressure, or whatever, so can be very tolerated for the life of the patient. Thank you very much for your attention, really. Thank you.
Thank you very much for that very informative presentation. The next session, the next topic for this session is an update on STEMI by Dr. Peter Salis. He's the Associate Professor, Academic Interventional Cardiologist and Vascular Biologist, Co-Director, Vascular Research Center, and Deputy Leader, Heart and Vascular Program, Lifelong Health Team, South Australian Health and Medical Research Institute. He's the current President of the Australian Atherosclerosis Society and Scientific Program, Chair Cardiac Society of Australia and New Zealand and Annual Scientific Meeting. He has a fellowship in vascular and hemopoietic biology at the Mayo Clinics. He has authored more than 130 full-text manuscripts. Dr. Peter Salis, you are talking to us. We only have a few members here, but over 1,000 people are watching you online. So over to you, Dr. Peter Salis.
Well, thank you very much, Dr. Fernando. Can I just confirm that everyone can see my slides okay? Good.
We can see your slides.
Terrific, thank you. Look, I'd like to thank the College of Cardiology in Sri Lanka for the invitation tonight. Before I begin, for those of you who are lovers and connoisseurs of cricket, I hope that you recognise the skyline of my home city of Adelaide, including the beautiful Adelaide Oval, which I'm currently looking over. It's a great backdrop for this presentation. Here are my disclosures. Now, over the next 30 minutes, as I update you on STEMI, what I'm going to do is to firstly revisit briefly the 2017 ESC Guidelines, and in particular, what was new in those guidelines. I'm going to use that as a launch pad to discuss recent evidence in the last 2 or 3 years for STEMI, particularly with respect to reperfusion, revascularization, and adjunctive pharmacotherapy, particularly with antiplatelets. Now, the cornerstone of STEMI management remains the prompt, complete, and sustained reperfusion of the infarct-related artery as quickly as possible, and certainly within 12 hours of symptom onset. Within appropriate timeframes, primary PCI outperforms fibrinolysis and remains the reperfusion strategy of choice. But in the real world, we're often forced to choose between primary PCI and fibrinolysis based on individual patient factors, access to timely primary PCI, and variation between regionalised systems of care. Irrespective of the reperfusion strategy selected, the key is to optimise and streamline pre-hospital, in-hospital, and after-hospital STEMI care processes to improve outcomes and mitigate complications. Now, compared to their 2012 predecessor, the 2017 ESC Guidelines had several notable changes in their recommendations. With respect to primary PCI, they upgraded to Class 1, that is, should be performed, radial artery access as the default access for PCI, and the choice of drug-eluting stents over bare metal stents. They had a relative upgrade to Class 2A for performing complete revascularization, including non-culprit PCI, during the admission of patients with multivessel disease and STEMI. And in contrast, they downgraded the routine use of aspiration thrombectomy to a Class 3 recommendation. Now, in addition, the 2017 ESC Guidelines introduced several new recommendations. These included, in patients with high LDL cholesterol above 1.8 millimole per litre, despite maximally tolerated statins, the use of adjunctive lipid-lowering agents, such as ezetimibe and PCSK9 inhibitors. Interestingly enough, based on expert opinion, the 2017 guidelines also gave a 2A recommendation of should be considered to complete revascularization in patients with cardiogenic shock who had multivessel disease. We're going to revisit that in light of new evidence a little bit later on. And they gave 2B recommendations to several new antiplatelet strategies, the use of parenteral cangrelor if patients had not already had oral P2Y12 inhibitors at the time of cath lab arrival, the possibility of switching to a potent P2Y12 inhibitor such as ticagrelor 48 hours or later after fibrinolysis, and the possibility of extending P2Y12 inhibitor use for up to 3 years in patients with high ischemic risk post-STEMI. Now, in addition to these new recommendations, the 2017 ESC Guidelines also made several very clear clarifications with respect to key time points in reperfusion strategy and target times. And this is depicted in this particular schematic here. I want to draw your attention to the key time point of less than 10 minutes for the time between presentation to first medical contact and STEMI diagnosis by ECG. And STEMI diagnosis is now called time zero and is the beginning of the strategy clock for reperfusion. Now, after STEMI diagnosis, the strategy for reperfusion depends on timeliness of being able to access primary PCI. Where a patient presents to a PCI centre, they should proceed to primary PCI with a view of achieving reperfusion with first device time of less than 60 minutes. If patients present to emergency medical services or to a non-PCI centre, the strategy depends on how quickly they can access primary PCI. If it is within 2 hours, they should be transferred to a PCI centre with a strategy of achieving reperfusion within 90 minutes. If they can't achieve that 2-hour time frame for primary PCI, they should have a pharmaco-invasive strategy. Now, the next slide depicts what pharmaco-invasive strategy means. This is the upfront prompt use of fibrin-specific fibrinolytics, such as bolus alteplase, retaplase, or tenecteplase within 10 minutes of STEMI diagnosis, followed by prompt transfer to a PCI centre. Assessment is made within 60 to 90 minutes for reperfusion success based on clinical and ECG criteria. If reperfusion has not been achieved, they should proceed as soon as possible to rescue PCI. If reperfusion has been successful, they should still undergo an early angiogram with a view to possible PCI within 2 to 24 hours. Now, since the publication of the ESC Guidelines, there have been several new studies to support this reperfusion strategy. One of the first studies to compare head-to-head primary PCI with fibrinolysis in patients who could access PCI within 2 hours was the Danish DYNAMI 2 study. This was a study that recruited patients some 20 years ago, 1,600 patients, and in their initial report of outcomes showed a striking all-cause mortality benefit for primary PCI. This year, the DYNAMI 2 authors have published their 16-year outcome data. And as can be seen here, primary PCI still outperforms fibrinolysis for composite endpoints with a hazard ratio of 0.86 made up of a composite of death and reinfarction. The absolute risk difference for reinfarction was 5.5% at 16 years, and there was a hazard ratio of 0.78 for cardiac death. Now, the DYNAMI 2 long-term data concluded that primary PCI postponed a major event by 1 year compared to fibrinolysis. Now, of course, in real-world practice, many of our patients cannot achieve primary PCI within 2 hours. Recent real-world evidence to support the pharmaco-invasive strategy in these patients was provided by this French registry called FAST-MI. FAST-MI studied 3,000 patients with STEMI who had presented within 12 hours of their symptom onset. And they compared 5-year outcomes in 3 groups. 50% of their cohort had had timely primary PCI within 2 hours of diagnosis. A quarter had late primary PCI outside of the 2-hour window, and the other quarter, the pharmaco-invasive strategy. And for unadjusted and adjusted analysis of death, MI, and stroke at 5 years, the late primary PCI group had significantly worse outcomes than both the early PCI group here in orange and the pharmaco-invasive strategy in red. In fact, the pharmaco-invasive strategy performed similarly to the timely PCI strategy with no increase in bleeding events. So this really does speak to the importance of making an early decision about the time it's likely to take to PCI. And if it is more than 2 hours, the choice of upfront fibrinolysis followed by transfer for PCI is clearly appropriate. Now, in the setting of primary PCI, we have a number of take-home evidence-based messages that we can now rely on. The first is that the default access site should be the radial artery based on outcome data, including mortality, from studies such as Matrix. What I'd like to focus on now is recent evidence that looks at the strategy of routine aspiration thrombectomy, the use of intracoronary facilitated PCI with thrombolytics in the cath lab, and the strategy for dealing with non-culprit disease in patients with multivessel coronary plaques who are both stable and unstable hemodynamically. Now, thrombus is clearly a significant problem in STEMI. It's associated with dystembolization, slow flow, microvascular obstruction, and increased adverse events. The 2017 ESC Guidelines gave routine aspiration thrombectomy a Class 3 or do not perform recommendation. And this was based on two major studies, the TASTE study and the TOTAL study. The TOTAL study randomized 10,000 patients with STEMI to an upfront strategy of routine aspiration or PCI alone and failed to show any significant difference at all in their primary outcomes of adverse events. In fact, this study showed a doubling in the risk of ischemic stroke with aspiration thrombectomy. One of the questions that remained after the original TOTAL study was, are there subgroups of patients who might still benefit from aspiration thrombectomy? And an obvious group that may benefit are patients who have large thrombus burden. The authors of the TOTAL study in 2018, after the ESC guidelines were published, provided this sub-analysis in which they looked at the impact of thrombus burden on outcomes and on the effect of aspiration. They firstly confirmed, as shown in this graph, that large thrombus burden was associated with higher event rates for cardiovascular death, cardiogenic shock, heart failure, and stroke, and that unfortunately, the aspiration thrombectomy strategy still failed to achieve any improvement in outcomes in this cohort of patients, and in fact was still associated with a doubling of the risk of ischemic stroke. Now, what this means in real-world practice is that many of us are no longer using this strategy, although sometimes it can be used as a bailout where thrombus remains. In fact, real-world data published just last year from the US CathPCI registry shows a more than halving in the use of aspiration of thrombus in the cath lab in the United States. And this is certainly the practice here in Australia as well. Now, if we can't rely on aspiration, how else might we try to treat thrombus in the cath lab? Well, previously, the use of adjunctive GP2B3A inhibitors has proven unhelpful. The use of intracoronary adenosine likewise has not resulted in better outcomes. And a strategy that recently has garnered interest is the use of intracoronary thrombolysis, a form of modified facilitated PCI. The TFUM study was a recent study from the United Kingdom in which 440 patients were randomized to 3 strategies of intracoronary placebo or 2 doses of bolus out of place before stent insertion. This was a study of patients who had presented early within 6 hours of their symptoms and had a proximal to mid-vessel occlusion with a low bleeding risk. The primary outcome here was a surrogate endpoint of MRI-determined microvascular obstruction at 1 week. And the strategy of intracoronary thrombolytics failed to show any significant benefit in this outcome, nor in infarct size. Now, there are ongoing studies of this strategy using different agents and different doses, but the reality right now is that we do not have an effective treatment that can deal with thrombus burden in the cath lab, and it remains a challenge for us. On a more positive note, We now have further data to support the use of drug-eluting stents in primary PCI. Consistent with the 2017 ESC Guidelines, this recent meta-analysis published in JACC last year compared outcomes for drug-eluting and bare metal stents in 11,000 patients across 15 trials. And they demonstrated that at a follow-up of 3 years for the primary composite of cardiac death, reinfarction, or target lesion revascularization, drug-eluting stents performed better than bare metal stents with a hazard ratio of around 0.65 to 0.75. Now, this study was unable to find a difference among different types of drug-eluting stents for the primary composite outcome, but did show a benefit of newer second-generation stents compared to first-generation stents for the problem of stent thrombosis. Now, since the publication of this meta-analysis, we have one new trial that is compared head-to-head two new types of drug-eluting stents. This was the BioSTEMI trial published in the Lancet last year that compared an ultra-thin strut stent called Orsaro from Biotronic, which has a biodegradable PLLA polymer that degrades over a year or longer and elutes sirolimus, with the standard workhorse drug-eluting Xience platform. This is a thin strut, durable polymer stent that elutes everolimus. This was a study performed in Switzerland, 1,300 patients. At 1 year, the composite outcome of target lesion failure was reduced by around 40% in patients with the Orsaro stent, driven by signals that were non-significant for cardiac death, target vessel MI, and target vessel revascularization. Now, the study was not without its limitations, but it does suggest that as we proceed towards newer stent design, particularly with thinner struts, biodegradable polymers, we may be able to reduce some of the inflammation and damage in the artery wall, some of the risk of thrombosis, and this may improve our outcomes. The other area that has gained a lot of research interest in the last few years is that of dealing with non-culprit lesions at the time of STEMI management. We know that about 50% of patients with STEMI will have obstructive lesions, angiographically more than 50% in their non-infarct related artery. And these patients are associated with an increased risk of adverse outcomes, including mortality. The 2017 guidelines gave a 2A recommendation of should be considered the complete revascularization, in other words, PCI of the non-culprit vessels during the index admission. Now, this was based on 4 intermediate-sized trials available at the time, PRAMI, CULPRIT, DYNAMI 3 PROMULTI, and Compare Acute, each of which had slightly different study designs, but each had shown a reduction in the primary composite outcome, however, driven by the soft endpoint of target vessel revascularization. Now, since the 2017 guidelines, we have a new, very important addition to this space, and that is the COMPLETE study. This was published last year. It was the first and largest study definitively powered to look at hard endpoints in the setting of complete revascularization. This took 4,000 patients, and some interesting points in the study design. The non-culprit artery PCI was randomized after the index procedure. Patients who had complete revascularization could have the non-culprit vessels treated during the admission or within 45 days after discharge. Most of the patients in the complete revascularization arm had complete revascularization achieved. The lesions tackled were relatively straightforward, low syntax score lesions, and cardiogenic shock was an important exclusion factor. The data for the COMPLETE trial showed a 26% relative reduction in the composite hard endpoints of myocardial infarction and cardiac death. This signal was driven by a 32% reduction in recurrent MI, non-significant for mortality. Looking at a softer composite secondary endpoint, which included revascularization, we see a 50% relative reduction. Impressively, an 82% reduction in ischemia-driven revascularization. Now, this data is likely to lead to a Class 1 recommendation for complete revascularization in patients with multivessel disease and STEMI. But there are key questions that remain. How should we define significant non-culprit lesions? Should it be angiographic, as it was for most patients in COMPLETE? Should it be by FFR? Should it be by intracoronary plaque imaging with OCT or IVUS? Another key question is, when exactly should we be tackling these non-culprit, non-infarct related lesions? Now, the COMPLETE trial was not designed to specifically look at this question, but this sub-study does give us some reassurance. In pre-specified analysis, the authors demonstrated that the time of non-culprit PCI, be it within a hospitalization or shortly after discharge, did not affect the overall study size effect for complete revascularization. In other words, it worked at both time points. Furthermore, on landmark analysis, they demonstrated that the benefit for the hard endpoint of MI was driven after the 45-day period. What this means is that we have up to a month and a half to tackle these non-culprit arteries, although in reality, as a lot of patients do fail to reattend after discharge, many of us, certainly in my country, are tackling these lesions during the index admission. Now, there is one cohort that does not do well with non-culprit PCI, and that is the cohort of cardiogenic shock. Now, I mentioned that the 2017 ESC Guidelines gave this a 2A recommendation based on expert opinion, but we subsequently have data that would suggest otherwise. Shock, of course, affects about 15% of patients with STEMI. About 80% of these patients will have multivessel disease. And throughout the last 2 decades, very few treatments, with the one exception of expeditious culprit vessel PCI, have been able to shift this mortality endpoint. CULPRIT-SHOCK was a study of 700 patients who were randomized with multivessel disease and shock in STEMI to either culprit-only PCI or multivessel PCI at their index procedure. The 30-day outcome of all-cause mortality and renal replacement therapy was 17% higher in the multivessel PCI group. And at 1 year, although there was not a significant difference in the composite outcome, you can see here the signal towards better result with culprit-only intervention. Now, there's one particular group that does very bad with non-culprit intervention in these patients, and they are individuals with shock who have their culprit lesion in the proximal LAD or left main. Tackling the right coronary or circumflex artery in these patients is associated with a very high mortality. And so several subcommittees have now recommended against non-culprit intervention during the index procedure for patients with cardiogenic shock. Now, in the last 7 or 8 minutes, I'd like to discuss the emerging evidence we have that is new in the field for the use of antiplatelets. Standard practice post-STEMI, like in all ACS, is to use dual antiplatelet therapy in most patients for a year, with preference for the potent P2Y12 inhibitors ticagrelor and prasugrel, based on data from the Plato and Trident-TIMI 38 studies. Recent studies include addressing the question of, can we use ticagrelor instead of clopidogrel in patients who have been fibrinolyzed? Now, as you know, fibrinolysis is associated with a bleeding risk, but also an increased platelet reactivity. Neither Plato or Trident-TIMI 38 included patients who had had thrombolytic therapy. So the TREAT study looked at patients who had been fibrinolyzed and compared outcomes for ticagrelor versus clopidogrel. They published their 30-day safety data, which showed no major difference in major bleeds between the 2 groups. Here we see 1-year efficacy data showing that ticagrelor is comparable, but no better than clopidogrel for the composite of CV death, MI, or stroke. Similarly, there was no difference in major bleeds, but ticagrelor was associated with a higher rate of minor bleeds. I think it's fair to say that this data supports the 2B recommendation of using ticagrelor after fibrinolytics, but also suggests that it is not essential for us to switch patients from clopidogrel to ticagrelor in this particular cohort. Another interesting question that has seen some recent airtime is there one potent P2Y12 inhibitor that performs better than the other? The ISAR-REACT 5 study, published last year, compared the performance of prasugrel to ticagrelor in 4,000 patients who had presented with an ACS, about 40% of whom had had a STEMI. The study hypothesized that ticagrelor would do better based on its pleiotropic actions and its mechanism of platelet inhibition, and also speculated that it would be associated with a lower bleeding risk. In my country, for the last 5 years, ticagrelor has certainly superseded prasugrel in the treatment of patients with STEMI and broader ACS, largely because of concerns around intracranial hemorrhage. Surprisingly, ISAR-REACT 5 showed a benefit of prasugrel over ticagrelor for the composite of death, MI, and stroke at 1 year, shown here, with a number needed to treat of only about 40. There was no significant difference in major bleeds. Now, this study was not without its flaws. It was only performed in 2 countries. It was open label, and perhaps most importantly, more than 30% of patients in each arm did not end up on their assigned study drug. So while this study requires further interpretation and consideration, it does suggest that prasugrel is not yet dead and may well be a viable, potentially even better alternative than ticagrelor. The other interesting development in the field has been, can we shorten dual antiplatelet therapy after ACS and STEMI? An interesting approach has been to withhold aspirin after just a few months, continuing ticagrelor alone to reduce bleeding risk. Amongst several studies published in the last 2 years, the TICO study from Korea is the study that has specifically looked at the ACS cohort. TICO randomized 3,000 patients with ACS who had an invasive strategy, all of whom had had the Orsaro stent, to either 12 months of DAPT with ticagrelor and aspirin, or to discontinuation of aspirin after 3 months and continuation of ticagrelor alone. The study reported a primary composite of bleeding and ischemic events that was 34% lower in the ticagrelor monotherapy group, and this was driven by a reduction in major bleeding that appeared at the time of aspirin discontinuation, shown here. Now, just last week at the TCT virtual meeting, the results of the TICO STEMI sub-study were presented. Now, this involved 1,100 patients from the TICO cohort, underpowered to look at the primary endpoint, but signals suggestive of a similar benefit, particularly with regard to a striking reduction in major bleed. And one of the take-home messages was that patients with a high bleeding risk do particularly well with ticagrelor monotherapy after 3 months, with a number needed to treat of only 22 in this sub-study to prevent major bleeds. Now, a caveat here is that patients with complex disease who have complex PCI do have a signal for higher ischemic event rates if you stop aspirin early. And these are almost certainly going to be patients that we should be continuing DAPT for a full year. The Twilight STEMI study is currently in design and will explore this question in more detail. Another quick strategy to consider to reduce bleeding risk is tailoring antiplatelet use based on genotyping. Amongst Caucasian patients, about 30% fail to have a response to clopidogrel, mostly due to a loss of function mutation in the P450 hepatic enzyme that metabolizes its prodrug. The Dutch-based popular genetics study, published last year, compared the strategy of 12 months of DAPT with ticagrelor and prasugrel and aspirin to a genotype-tailored approach. Now, in this particular arm, if patients had the loss of function mutation, they got ticagrelor or prasugrel for a year. But if they did not have the mutation, they were treated with clopidogrel instead. And at 1 year, this strategy was non-inferior to standard DAPT for a primary composite endpoint of thrombosis and bleeding, but with a 22% reduction in major or minor bleeds. I think a very elegant look into the future of how we may be able to individualize antiplatelet therapy to get lower bleeding rates. Now, in the last 2 minutes, I just want to talk about other pharmacotherapies of note. We are getting lower and lower with our LDL cholesterol targets, with the ESC guidelines most recently recommending a target LDL of less than 1.4. We're getting better with our management of diabetes with SGLT2 inhibitors and GLP-1 receptor agonists. Beta blockers remain a contentious issue in patients who have preserved left ventricular function and normal blood pressure after STEMI. The data in favor of beta blockers is actually very old, predating reperfusion and revascularization strategies. And the contemporary data, like this recent registry from the French FAST-MI, suggests that long-term beta blocker use post-STEMI is not associated with a mortality benefit. This is a space that clearly needs further research to see if we can discontinue beta blockers early in this particular patients. My last slide is a suggestion that we should be looking at the repurposing of old agents for new mechanisms. The area of inflammation is a growing area of research in atherosclerosis. We know that a lot of patients on high-dose statins post-STEMI will have residual inflammatory burden. And the old anti-gout drug colchicine now has several runs on the board to suggest that it can reduce cardiovascular events. I draw your attention to the Canadian COLCOT study published last year, which demonstrated in patients that had an infarct within 30 days using 1 tablet of colchicine per day compared to placebo resulted in a relative reduction of composite ischemic events by about 23%, largely driven by a reduction in stroke and revascularization. There is biological plausibility for this particular drug, and I think we will see more and more interesting data in this space. In the interest of time, lady and gentlemen chairman, I will stop there and I look forward to any questions. Thank you.
Thank you, Professor Charles, you joining us with the SLCC as a nominator from the APSC as with a joint symposium. And we will be open to now questions, and we have a few questions from the audience.
Yeah, it is actually, is Professor Mario online?
Professor Mario is online.
Yes. Yes.
All right. This question is for Professor Mario from one of our virtual audience. They ask how common is the microvascular disease and in the chronic ischemic syndrome.
Thank you for this very stimulating question. There have been several reports recently. The first one that comes up to my mind is the Carmichael trial, where in a consecutive patient referral for coronary angiography with typical angina pectoris, about 50% did not have a significant or no stenosis whatsoever. In this patient, in the Carmichael trial, they performed a specific testing for microvascular dysfunction and for coronary vasospasm, and they identified that 30% of these patients had the microvascular dysfunction and the remaining had the coronary vasospasm, and with a quote of patient in whom no specific mechanism was identified.
Do they belong to INOCA and MINOCA groups? The recently described?
Well, these are terminologies that somehow reflect the skeptic reaction of cardiologists when they are told this patient with typical angina has no stenosis. So they are puzzled and surprised, and they need somehow to, let's say, to put this patient in a separate basket. I don't think this is the approach of the future. I think the ischemic patient must be seen as a group that may be the consequence of different mechanisms, but they have the same prognosis, they have the same symptoms. Some of them may have a stenosis, some of them may have not. But the point is that even patient with the stenosis, ischemia may be precipitated by vasospasm or by microvascular dysfunction, because you remove the stenosis and ischemia remains. So the old distinction of INOCA may be misleading, because it may assume that if you have a stenosis, that is consistently the cause of ischemia. But this is not the case, as we have learned performing thousands and hundreds of thousands of PCI, and then facing that from 20 to 40% of these patients still are angina without the stenosis. So we should start to consider this before to prevent useless procedures.
Thank you. This is a question for Professor Peter. Professor, what is the best combination antiplatelet NOAC for patients with STEMI complicated with atrial fibrillation following primary PCI?
So thank you for the question. It's an important question, very topical. There have obviously been several landmark studies in this space recently, the best of which was the Augustus study, which used a 2x2 design to address this very question. Augustus showed that a combination of a non-aspirin antiplatelet, preferably clopidogrel, coupled with a dose-appropriate of a NOAC, apixaban in Augustus, was the best strategy. The point here to note, though, is that for the first week in the study, patients did receive triple therapy with aspirin added. After a week, the group that was on the P2Y12, predominantly clopidogrel and apixaban, had lower bleeding events than the use of triple therapy and no significant increase in ischemic events. Now, there are, of course, some caveats there. The caveats are really tailored to whether patients have a high ischemic risk or not. Patients in whom multiple stents have been deployed, patients who have significant residual disease, for example, may benefit from a longer course of triple blood thinners, including aspirin. My own practice is to use aspirin as a third agent only for the first week, and thereafter to move to clopidogrel and apixaban. The use of ticagrelor in these patients in sub-analysis has been associated with a slightly higher bleeding risk. And as a result, where possible, I tend not to use it in my own practice. Hopefully that answered the question.
Thank you. There's another question from one of our virtual audience to Professor Mario. The anemia can complicate angina. What is the optimal hemoglobin level for patients with chronic coronary syndromes?
Thank you. Of course, anemia may complicate angina, and the optimal hemoglobin level should be at least higher than 12 grams per ml. But the problem is one should identify why the patient is anemic, and if possible, to correct the cause of anemia. It may even solve the problem of angina if the patient was symptomatic, because, I mean, when you have 6 grams of hemoglobin, you may be ischemic even without no cardiac per se dysfunction. So anemia is an important topic to be considered in these patients, yes.
Professor Peter, now the recent discussions on the ESC guidelines and the ESC sessions, that there was a concern about the loading of patients with ST elevation in my prior to angiogram, and they were discussing on a single end platelet regime. But in this part of the world, that our angiograms are not so frequently available for these patients. And what would you recommend for at the moment, what would you practice in oral ST elevation MI and non-ST elevation MI of those patients?
Yeah, so look, the context here in Australia are patients who present in rural and regional areas. And our approach there is that they do get thrombolized and they get loaded with clopidogrel, aspirin, and an anticoagulant, usually enoxaparin, before having their angiogram. With respect to what we do for primary PCI, based on the lack of benefit shown with ticagrelor preloading in the Atlantic study and the most recent ESC guidelines, our practice in my institution is now not to give the P2Y12 inhibitor until after we have seen the coronary arteries. In other words, we give the aspirin, we look at the coronary arteries, and then if we are going to proceed, we give oral ticagrelor or chewable ticagrelor on the table. There are also forms of chewable prasugrel. In other countries, they use a cangrelor in that particular setting, but there is no clear outcome data for that as yet, just pharmacodynamic data. So that would be my approach. In Australia, our cardiothoracic surgeons are often very reluctant to take patients to early bypass if they've had any exposure to P2Y12 inhibitors. And we occasionally get caught out, which is perhaps another reason to defer the P2Y12 until we've actually seen the coronary anatomy.
So in patients who do not have access to coronary angiogram, would you recommend dual antiplatelets?
Yes, I would. If the approach is that they will not get an angiogram within the 24-hour period, I would be using dual antiplatelets. It obviously depends on what your country predominantly uses. In our country, if they were fibrinolyzed, that would be aspirin and clopidogrel until we've seen the coronaries. If it was a non-ST elevation myocardial infarct, let's say somebody coming from a non-PCI center where PCI was delayed more than 24 hours, patients would get aspirin and ticagrelor in my country.
In centers where clopidogrel only is available, will that be the same practice to load only after you know the anatomy?
No, again, it depends on the timing of the angiogram. If we can access an angiogram within 24 hours, which is our practice, even for patients presenting in the country, we would be happy to do the angiogram first before giving the second antiplatelet. In patients where the angiogram will be deferred 24 hours, we would use clopidogrel basically at the time of presentation with subcutaneous enoxaparin as the preferred form of anticoagulant.
And at the same time, in a setting of an acute MI with or without cardiogenic shock, what are your concerns on complete revascularization versus CULPRIT-PCI at the moment?
So really, since the publishing of the COMPLETE study, most of us attempt complete revascularization in hemodynamically stable patients prior to hospital discharge. Less and less are we doing the non-culprit vessels at 3 o'clock in the morning. We would just often do the culprit vessel and then often attempt the non-culprit vessels maybe on day 2 after the index procedure. Sometimes we're quite happy to do it in the first few weeks after discharge if we can assure that it will be done. I think some of the contention in the space is what exactly constitutes a significant non-culprit lesion. I'm still of the belief that the area of subtended myocardium is important, as well as obviously the degree of stenosis and the ischemia burden. And so a small obtuse marginal branch or a diagonal branch, even if it is severely stenosed, I may be inclined to leave, but clearly a proximal to mid-major epicardial vessel I will be trying to do, and in most cases before discharge. For cardiogenic shock, we will only attempt the culprit vessel PCI. If the patient recovers and stabilizes hemodynamically, we may attempt the non-culprit vessels once they're stabilized.
Mr. Chairman, may I make a comment and a question to Professor Salis about this point? Am I allowed?
Yes, please, please.
Thank you. I really enjoyed your presentation, Peter. And I have noticed the enthusiasm of the international community eventually getting a study that allowed so-called complete revascularization after so many trials that were not so conclusive, at least. But forgive me if I am still a little bit skeptic. And the reason of my skepticism is basically for 2 reasons. First, because we remember, at least I'm much older than you, that in the past, several studies have proven that performing angioplasty on non-ischemia associated lesion was detrimental to the patient. And the second, because in the COMPLETE trial, there is one information that is completely missing, and that is, where does the reinfarction occur? They just counted the number of reinfarction, but they don't tell us if these reinfarction are in the area perfused by the originally culprit lesion, or is that in reinfarction is in a different area. In the past, there was a study that was called the Prospect trial. First author was Greg Stone, that showed that reinfarction can occur on both sides.
Correct.
So if you really count the new infarction in area different from the culprit lesion originally treated, that is the information to support complete revascularization. And this information is not included in the paper.
I think it's a great point, Professor Vasili, and I agree. And obviously in stable patients, the ischemia trial also gives us reason for caution to rush ahead. The CULPRIT trial, which was obviously a modest trial of only 250 odd patients, did recently publish 5-year outcome data, and they tracked where reinfarctions occurred between 1 and 5 years. And interestingly enough, in the PCI only group, the majority of infarctions occurred in the non-culprit vessel. Your points about the PROSPECT trial are very valid. You know, even with the use of a modality like IVUS, our ability to predict which lesions infarct is less than 20%. So I think your point's a valid one. It also needs to be taken into the context of new plaque stabilizing treatments. And I think the lower we get with LDL and the more effective potentially anti-inflammatory drugs might be, the less these lesions will be problematic. I will make the point here though that the concern about reinfarction to me is less about ischemia and more about plaque biology. Now, although plaque sealing has never been proven to be a mechanism of preventing infarction, we know that the process of myocardial infarction begets inflammation in plaque. Often inflammation is systemic. The infarct process itself is pro-inflammatory. It's been shown beautifully in a vast array of studies. And certainly for the first few months after infarction, those non-culprit lesions can be quite angry. And I think that's why we see some of the benefit shown in COMPLETE.
Yeah, there's, Professor Peter, now there's one case scenario. This is a true one. And he's a 32-year-old man, heavy smoker, no diabetes, no hypertension, coming in with chest pain, severe chest pain. ECG shows ST elevation on 2, 3 and AVF with the RCA territory. And there's a mild hypokinesis of the inferior wall, and it's an inferior wall MI. And he goes for, within 90 minutes, he goes for a coronary angiogram. The coronary angiogram reveals mid RCA. It's a large, big RCA, 4 millimeter RCA, as a large thrombus, but through the thrombus, there's flow, and there's a 50% plaque. And would you do the stenting at this stage, or you defer it? There's flow across the right coronary, but there's a large thrombus, and there's a plaque as well.
No, it's a very interesting question. Anecdotally, I have deferred such cases. Despite some of the trials that I quoted, I've had cases exactly as you've described, where we've taken patients off the table after establishing flow, used 48 hours of maybe tirofiban, and then brought them back when the flow was lessened, when the thrombus was lessened, to reevaluate the plaque, either angiographically or with imaging or FFR, and then with performed stenting. The area of deferred stenting is made a little complex at the moment because the defer study was not particularly favorable for the deferred stenting approach. There are ongoing studies that will help us address that question. The other approach in these people is to buck the evidence and to try aspiration, provided that your technique is safe, that you keep good catheter engagement and negative pressure to prevent clot obviously going outside of the coronary bed, and to try to lessen the clot burden. My own practice is often anecdotally to try aspiration if I'm concerned about thrombus, and or take the patient off the table, 48 hours of tirofiban, and then reassess.
Yeah, this patient's blood counts were not ready at that time, and the patient was treated with abciximab, and the stenting was deferred. 2 hours later, the full blood count came as 21 grams of hemoglobin. Now, there is a consensus that this patient could be not because of the polycythemia, it's not because of the smoking, but because of the PRV. At this stage, would you go and stent this patient? And if
I missed the last.
Yeah, this patient is suspected to be polycythemia rubra vera. And at this point, would you stent this patient, And if you stent, what is the antiplatelet regime?
So it's a challenging scenario, isn't it? Look, if the patient was stable and I had taken them off the table, I would still give them the benefit of the course of abciximab before reassessing them. If on reassessing I felt that the lesion was significant, I would be inclined to stent. I would stent with a new age, new generation drug-eluting stent. And if their platelet count was above 50, and in consultation with their hematologist, I would still use aspirin and ticagrelor.
Thank you, Professor Peter, and thank you, Professor Mario. And it's an excellent presentation and excellent symposium with a discussion. On behalf of the College of Cardiology and the Council, we will be extremely thankful to you. Thank you very much.
Thank you.
Thank you. Bye-bye. Thank you.
Ladies and gentlemen, we'll be taking a short tea break at the moment, and we return back in 15 minutes time. For the virtual audience, I'd like to, in 5 minutes. We'll be back in 5 minutes because we are a little ahead of time. And for the virtual audience, I'd like to announce that the winners for the second competition have been declared. So the winner of the rupees 10,000 voucher is Vasana Ranavira, and the winner of the rupees 5,000 voucher is Prasad Tilakaratna. So congratulations to both. And you can collect your vouchers from the SLCC office at your convenience. Thank you.